So our topic now, which is our final one in 50 Shades of Immunology, is the use of immunology in diagnostic techniques. Now, many years ago, the USMLE came out and said that they would no longer expect medical students to know how to do laboratory techniques, because that, of course, is the purview of a laboratory technologist. And there has to be a limit to what we expect our physicians to do that we can reasonably get other personnel to manage. But that doesn't mean that you can totally flush this information because of the fact that you have to know what test to request from your laboratory. And then you need to know how to interpret the results that come back. So what we'll do in this chapter is talk about the principles of various laboratory procedures with an eye on knowing how to use them in medical diagnosis, but much less of an emphasis on the details like, add 5 milliliters of this and wait 5 minutes and okay? So first of all, let's accept the fact that the things that we have been talking about in all of our previous discussions have been things happening at the molecular and cellular level. So they are not visible to the naked eye. And so many of these tests, which continue to be in use today, originated during a period of time when early immunologists figured out that if you put the product of an immune response in a test tube with its antigen or immunogen, that you could get a visible response when enough molecules were collaborating together. So that brings us to our discussion of agglutination and precipitation. And really, these are exactly the same thing. Agglutination and precipitation involve the settling out of something from a liquid. So agglutination refers to particles being separated out. Those would be things like red blood cells or latex beads. Precipitation involves the settling out of proteins and making them insoluble from that liquid. So as long as you realize if it's a latex bead or a red blood cell, it would agglutinate. If it's anything else, it would precipitate. Then you don't have to worry about anything more than that because the same principles of how these processes work are universal. Now, let me go back and give you some information about how we define the parts of an antibody molecule. And much of this is historical. Honestly, we would never in this day and age be treating antibodies with digestive enzymes like pepsin and papain. But back in the day, when they didn't know what antibodies did, they would cut them up and see what happened to them when they were cut up. Sort of like early surgeries. If you want to know what the heart does, you remove it and you find out that your patient doesn't do so well. Well, early immunologists cut antibody molecules up with digestive enzymes. And they learned that if you cut an antibody molecule with pepsin, what would happen is that you would cut behind the hinge that we now know exists, and it would leave in the front, still attached to one another, the two antibody binding arms. Each antibody binding arm is called an FAB, fragment antigen binding, and if I put two of them together, I refer to it as an FAB prime 2. So pepsin would create that molecule still intact on the top end. So there are two combining sites that I could use to bind to two identical materials and cause them to become large and settle out of a liquid. When I treat an antibody molecule with papain, by contrast, notice that the cut forms in front of the hinge. So I will generate two separated FABs, but they would not be able to bind two epitopes of immunogen together in order to cause them to settle out. Okay? So All I need to realize is that if I want to perform either precipitation or agglutination, I have to have those two arms still being held together. And of course, you've met the term FC, which stands for fragment crystallizable, and I don't think there's any reason for you to know that. They simply found that when you put the test tube in the refrigerator overnight, it would crystallize, and that was why they named it. But remember, that would only be formed after cleavage with papain, because if I cleaved with pepsin, then I'm going to destroy that tail and it would not be functional for binding to an FC receptor. Now, the development of antibody-antigen complexes is really a universal principle that you need to understand. Remember that in the human body, these things will form in the tissue, in the lymph node, in the blood, and they will typically be cleared then by the spleen by opsonization. But when I think about how antigens and antibodies interact with one another, realize that every antibody, if it's a monomer, is going to have two binding sites. And so if I were looking in my patient at the time immediately after exposure to a pathogen, I would expect that I would find molecules of the pathogen's production, and I would not as yet find antibody molecules in response. Because remember, it takes 10 days to 2 weeks to develop a healthy, detectable antibody response. So I would say that during that first 10 days or so, my patient would be in a period of free antigen excess, because the molecules that are bound together, the antibody binding to antigen, would indeed be cleared out in the spleen. So what I would find persisting in the serum of that patient would only be those free molecules of antigen. As time goes on and the immune response has time to crank up, I will at some point reach the level where I have exactly the right amount of antibody molecules being made so that every single molecule of antigen is being bound and cross-linked. And you notice that my complexes at this point are very, very large because of the cross-linking and create a tremendously high amount of precipitation or agglutination, depending on what I'm talking about. I refer to this as a period of equivalence between antigen and antibody. But remember, I'm going to find all of my complexes removed from the system by the spleen, and what I would find free in the serum would be neither free antigen nor free antibody, right? Because everything that's being complexed is being cleared out. As time goes on, my patient would enter a convalescent period where their continued production of antibody and hopefully their diminishment of the antigen's life cycle is going to cause the fact that if I look for free molecules that haven't been cleared out by precipitation and agglutination in the spleen, what's left behind is free molecules of antibody. And so I would say that during this period of time, I would be able to measure a rising titer of antibody in my patient's convalescent serum. Okay? Now, this is an absolute. It doesn't matter what I'm talking about as far as the pathogenic process that's generating an immune response. I will be in antigen excess, followed by a brief period of equivalence, and then I will lapse into antibody excess in the serum. And so realize that when I'm thinking about trying to diagnose a condition in a patient, if I'm looking for the problem very early on, I'm going to look for an antigen assay to tell me if the pathogen is there. If I'm looking to find out if the person has had this problem before, I'm going to look for a titer of antibody that is elevated. But in either case, whether I'm using an antigen assay or an antibody assay, it's always true that there will be a period of time when I cannot easily detect either antigen nor antibody in free form because the complexes are very large and are being successfully cleared out in the spleen. If I'm looking at a test tube, it's going to be the precipitate or the agglutinate at the bottom of the tube. But if it's in the body, those are being cleared out in the spleen. So let's go through a few of these assays that they like to mention on your exam. We already did one, which was the ABO agglutination assay. And if you remember that from our previous discussions, remember it's going to be important for you to remember that in that case, I'm looking for IgM isohemagglutinant, right? And IgM is a very large molecule, a pentamer, which has 10 combining sites. So it's possible for an IgM molecule to agglutinate red blood cells by itself. But as you'll notice in the other agglutination tests that I'll describe here, I'm going to have to add an additional antibody to bind to the first one so that I can make the complexes large enough that I can actually cross-link between two red blood cells. So the most famous of these is called the Coombs test. And of course, they will expect you to know how this works in the context of a child with hemolytic disease of the newborn, or in the case of a mother when I would need to try to prevent her from causing this problem in a subsequent pregnancy. So if you notice, I have two basic forms of the disease, the direct test or the indirect test. It's always true that the indirect test of any pairing has one additional reagent. That's what makes it called the indirect test. Okay? Now, to diagnose the problem, let's just take hemolytic disease of the newborn as an example. To take the child and determine if there is a problem with them having their red blood cells destroyed by maternal antibodies, then what you would want to do is then take a sample of blood from the child, and you're asking the question if those red cells are already coated with antibodies from the mother. So to detect the agglutination, since I'm looking specifically for an IgG antibody, my only reagent to add to this is so-called Coombs serum, which is simply anti-human immunoglobulin G. And so if I have the child's red blood cells that are already coated with the maternal antibodies, when I add Coombs serum to that, what would happen is that the antibody against the antibody would cause the cross-linking between the red blood cells that have been coated in that way. And so I would be able to get agglutination because the antibody between the two would cause the binding together of the red blood cells and cause them to settle out of the circulation, okay? And again, I have to use Coombs serum because I'm not looking for an IgM, I'm looking for an IgG. Looking at the indirect Coombs test, realize that I'm going to do this in order to look at whether or not the mother is making antibodies against the child. So this would be done to test the mother, but to ask the question, for example, is a multiparous woman who's Rh negative, is she safe, or do I need to counsel her that the chances of her causing a very bad disease in her fetus should be reason for concern? So the indirect assay is going to look for antibodies in the serum of the mother. And I need to start with that sample of serum from her. I need to then put her serum into culture with a source of Rh positive red blood cells, and then add Coombs serum to that so that I then am creating this same complex of her antibodies binding to the red cells that have been provided, and then adding the anti-serum in order to cross-link between them. If I get agglutination in any case, the direct test tells me the child is developing HDNB. The indirect test tells me the mother has pre-existing antibodies and should be counseled. Next, one of the most common immunologic assays that is used in medicine is the EIA, also known as the ELISA, which stands for Enzyme-Linked Immunosorbent Assay. And really, this is exactly the same test as the RIA, or radioimmunoassay. The only difference is in the actual final step where I'm adding the material that will cause me to see a change in the result. So, as you might anticipate, the radioimmunoassay is going to add radioactivity so that an increase in radioactivity would be detected on something like radiographic film. And the EIA, the E stands for enzyme. So what I'm going to do is detect a color change that is caused by the enzyme acting on the substrate that you provide for it. Now, both of these tests, the RIA and the EIA, are extremely sensitive. And indeed, if they have a fault or a flaw, it's that they produce false positives, because they're capable of detecting 10 to the minus 9th grams of material. So usually you'll find these assays paired with an insensitive assay in order that if both of them are positive, I have a fairly good degree of security that it is a case where it is a true positive and not a false one. So if we think about, as an example, the test that we use for screening for HIV infection, the first step of the test is to coat the wells of a microtiter plate with a viral antigen. Okay, what we typically use is the P24 capsid antigen. So thinking about my microtiter plate here, notice that once I have got antigen in all of the wells, the P24, I then will add serum from the patient, and my patients are going to be A through H here. I will add serum undiluted in the first column, and then I will make a serial dilution of that serum across the plate, stopping before the last two columns in order to leave myself room for a positive and a negative control. So I don't know from this designation whether I've made a 1 to 2 or a 1 to 3 or a 1 to 4 or whatever I've done, and different laboratories will do that differently. But regardless, I think you can imagine that starting with the undiluted serum furthest to the left and then moving toward the right, I'm going to have less and less antibody of any kind as I move toward the right. So there should be a point at which I've diluted the serum so much that I no longer get a positive result. And when I find that last well that has a positive result, that is what I call the titer of the antibody. It's the dilution in that well, in the last positive well for a given patient. Now, that was a little bit off of the sequence. So going back to having the dilution of serum, I'm now going to add a second antibody. And my second antibody is going to be an anti-human immunoglobulin. something made in animals perhaps, that will react with the antibodies of a human. When I add that to all wells universally, and then that antibody is conjugated to an enzyme, when I finally, at the last step, add the substrate for that enzyme, I will get a color change if all of these things happened in sequence. The antigen that I put on first, plus the serum of the patient, plus the anti-serum with the enzyme attached. If that sandwich of antibody, antigen, and anti-antibody occurs, then I would get the color change when I added the substrate. And that's indeed what I'm going to detect by seeing which well is the last one positive. Immunofluorescent assays, again, come in two manifestations. We have direct versus indirect, and as I said before, the indirect always has an additional reagent. So we use direct fluorescent antibody tests to identify antigen in a specimen in those cases where I have a pathogen that is difficult to visualize or is very small or has some other issue that makes it hard for me to see with a microscope. So that particular test, if I were using as an example, let's say, looking for pneumocystis pneumonia. Remember, pneumocystis is a very small fungal antigen that is found extracellularly in the exudate in the lung, but the patient has a lot of trouble expectorating, so I have a necessity to go in after it and do a biopsy to get a tissue specimen, okay? So using that analogy then, that's my biopsy source. It would be a lavage or a biopsy of the lung. I'm going to add an antibody that has been created in an animal by repeated inoculation with pneumocystis. And those anti-pneumocystis antibodies will detect the pneumocystis antigen in the biopsy specimen from the patient if they're present. Since I have added a fluorescent tag to that antibody, it means that now the tissue will fluoresce and become very easily visible in spite of the fact that the organism is very small in size. So fluorescence is the positive result. In the indirect version, this is normally used for detecting autoantibodies in patients. So in many of the autoimmune diseases that we talked about, I could look at the distinctions between the glomerulonephridities that were either type 2 or type 3 by detecting whether the deposits of fluorescence were linear or granular, if you recall. So in this case, I'm going to start with a serum sample from the patient, and I'm going to add it to a known sample of normal tissue. I'm looking for antibodies that the patient is making against the tissue. So it could be kidney, for example. If I then have those antibodies bind, I can't see them. Remember, this is happening at the molecular level. But when I subsequently add a fluorescent labeled antibody against human immunoglobulin, an anti-human immunoglobulin, now the tissue will fluoresce. And that gives me the knowledge that my patient was making autoantibodies against that particular cell or tissue. Finally, we have the fluorescence-activated cell sorter, and by all means, out of this chapter, this is probably the most heavily tested of the immunological techniques, because as you'll see in a moment, it's a very nice way for them to test whether or not you are a memorizer of medicine or an understander of the process, because there's really no way to utilize this information without understanding multiple steps in a process and putting them together in a different fashion to solve a problem. So You don't have to understand the mechanics of the machine. This is a very complex computer-driven machine that is way beyond our discussion here. However, the goal of this apparatus is to separate cells out of a complex mixture after they have been treated with fluorescent dyes in order to cause them to light up. Okay? It simply is going to take the mixture of cells, pass them in a single file through an electromagnetic aperture, and then analyze, do they have one color or both? Or do they have them very brightly, or do they have them very beneath the level of the background noise of fluorescence? So if you look at what will come out of the machine, it will give you a graphic, and it will tell you what it is plotting against what, okay? If I took two dyes, and let me see if I'm sure on what I did here, a blue labeled antibody against CD3. So here is my CD3 axis, and a yellow labeled antibody against CD19. So here is my CD19 axis. Okay. Notice that every time a cell passes through the aperture, the machine is going to make a dot on the paper that reflects that it counted that cell and was measuring the intensity of fluorescence and making the dot in increasing intensity of fluorescence further to the right on the x-axis or further toward the top of the y-axis. So the most brightly blue cells are up to the top of the y. The most brightly yellow cells are far to the right of the x, which means that my cells that are falling beneath the background level of the standard non-label wearing cells in the mixture are going to be found in the lower bottom quadrant, lower left. And if I had cells that were brightly colored both with blue and with yellow, they would be in the quadrant that is in the upper right. So my double positive cells would be there, and you realize that the reason why I have no dots in that quadrant is because of the fact that there's no such thing in your body as a cell that wears both CD19 and CD3. CD3 is a marker for T cells, and CD19 is a marker for B cells. So I don't have any such thing as a cell that would have both. I do, by contrast, have a number of cells in the peripheral blood that would not have either CD3 or CD19. They could be my neutrophils. They could be my eosinophils, okay? So understanding how to interpret this graphic has become a really predominant mechanism of torture in order to make certain you know what the markers are that we measure cells with or count them with, and understand when I would find various quadrants to be empty or full if I had an immunodeficiency disease, if I had a case where I was missing a molecule like CD40 ligand on T cells, then I would use flow cytometry to detect its absence, okay? So we'll do some questions with that at some point in the development of our website. But for now, that completes our discussion of the chapter, and I only want to go further into one point that is now a hashtag Make Me Care Again, as follows. Hepatitis B virus has three major antigens. C is the main core, E is the second core, and S is the surface. Patients make antibodies against all three antigens at some point in the course of hepatitis B infection. A prognostic indicator of recovery is the disappearance of the S antigen before 6 months post-infection. Can you explain why this would be so in the context of what you know about the development of immune complexes. Stop your video, work this out on your own, and when you've got your mind wrapped around this, come back and we'll go through it. All right. So, thinking about what I said before in the interaction between antigens and antibodies, remember that I have three standard phases. I have antigen excess, I have equivalence, and I have antibody excess. And if I superimpose upon that the fact that in hepatitis B, I have three antigens, C antigen, and E antigen, and S antigen, realize that in the period of antigen excess, I would be able to measure each of those early in the infection. In fact, as you'll see, these begin during the asymptomatic period. So I don't typically go out in a population and just randomly test them for hepatitis B. I guess that would be a scenario that you could pick up on a pre-employment physical, but we don't find that a very beneficial set of markers because the persons who have all three of those in excess are in an asymptomatic period. It's not until they begin to have symptoms at about 2 months that you will see I would still be in antigen excess for S and for E, but for C, I would have shifted over to making antibodies against that. So notice that the equivalent zone there is going to be back in the asymptomatic period, so that already when my patient comes in with symptoms, I already find that I can measure antibody against C. Okay? First of all, I think you should understand, and I hope this is not needing to bludgeon you with, it would be IgM first, and then it would switch over to IgG. But the point is that I use the finding of that antibody as my measurement of infection in that patient. That's my diagnostic antibody. Next, and you'll find it's very handy, although not universal, these antibodies appear in alphabetical order. So my second one that is going to go through this transition within the symptomatic period, and it's variable in time, but my second one that is going to go from antigen being present and measurable in excess through a narrow equivalence and then into antibody excess is going to be the E antibody. And in between the two, the equivalent zone between them. Notice the equivalent zone is always the period of time when the antigen and antibody are in just the right amount so that they are being cleaned out totally by the spleen, and there is neither excess molecules of antigen nor excess molecules of antibody. The one that makes a difference, and the one that was referred to in the hashtag #MakeMeCare question, is the finding of the S antigen, which will persist generally up until before 6 months. And the disappearance of the antigen excess with S is followed by an equivalent zone and then a measured rising titer of S antibody in that patient. So notice that in hepatitis B serology, that equivalent zone is indeed the window period. Everybody makes a big deal of that phrase, but it's simply the period of time where the S antigen disappears Notice I can no longer measure this being in excess. There's a period of time when I can't measure either S or anti-S, and then I'm able to measure a rising titer of S antibody. If this does not happen before 6 months, then I define the case as a chronic case of hepatitis B. That is the medical definition of chronicity in this disease. If I have a window before 6 months, I'm going to recover. If I do not, I'm never going to recover. I'm a non-responder, and I'm incapable of making that antibody. So realize the only thing that makes this particular serological picture different than others is the fact that the antigens will go through this sequence in alphabetical order, which just happens to be rather handy for remembering it. But when I think about what the antigen-antibody pairs do for my understanding, realize that my diagnostic antibody is going to be my C antibody. What I'm going to learn from my E antibody is whether or not my patient is extremely contagious. And the reason for that is that the presence of E antigen in the blood is corresponding with the presence of viremia. So if a patient has viremia, they're more contagious than they would be if they didn't. So that's how I use that pair. Excess of antibody against E means not as contagious as a patient who has excess of antigen E. Okay? And then finally, as you notice, my S pair is my prognosis indicator. That's going to tell me whether my patient's going to recover or not. If I pass the 6-month time frame post-exposure and my patient has not had a window period or equivalent zone, by definition, they are going to go chronic and will not recover. Okay? All right, the only remaining thing here is the normal list of things that you should ask yourself as you leave the chapter. Make sure you understand how these procedures are used. Don't worry about the details of how they're performed, but understand where they're used and what you would learn from them. Particularly with the fluorescence activated cell sorter, try to practice with those graphics and realize when they would be useful for testing purposes.